Good afternoon, everyone. I am Dr. Vandana Iyer from AIIMS Nagpur. I'd like to thank AIOS for giving me this opportunity to present this in this faculty talk. My topic is retinal detachment surgery, tips and tricks for beginners. So first and foremost thing is to choose the right case. So see, as we have just finished our fellowship, we would be at different skill levels. So it's very important to assess yourself, see your comfort zone, and take cases initially which the ones you are comfortable with. So after that, you check the patient profile. Go ahead with the easy cases first. The ones who are BPL, the ones who are free cases, charity cases, go ahead with them first and then only move on to the demanding and the VIP cases. So again, select the right case. Simple cases, single break, fresh RD, less PVR changes, select them first. As you move on, you will be able to do the more complex ones. So initially just avoid the advanced PVR ones. Then preoperatively, you have to plan very well. You have to gauge whether you have everything available to manage the case, from instrumentation to visualization, raw materials. Take a proper consent in the language of the patient. Proper documentation is very important from pre-op, intra-op to post-op. So salient points in the history is the duration of the symptoms. It's very important to know for how long the patient has not been seeing well. If he's not been seeing very well for a long time, that means a long-standing RD, and you may not have a good visual outcome. In case of macula on RD, a patient presents to you with flashes, you have to have a high index of suspicion while examining the patient. Again, any history of any preceding trauma or intraocular surgery which has led to the RD is to be known. History of amblyopia preoperatively itself will lead to the visual outcome worsening. Again, systemic history of diabetes, hypertension, heart disease, any exposure to any addictions, tobacco, nicotine will affect the optic nerve function, again affecting your visual outcome. So you have to make a large diagram before the surgery. It has to be known whether the patient is phakic, aphakic, pseudophakic. Make a plan for the surgery, whether it is amenable to buckle or width, depending upon whether you can indent it well. Also prognosticate the patient in terms of visual as well as anatomical outcomes. Say so many % chances of the retina attaching in the first go. Fresh RD, it is 60%. Old RD is like 30 to 40%. Twice, thrice operated means 10% or maybe no chance to fix the RD. So anatomical outcome has to be given. Whether the vision will improve or remain the same, that also has to be known by the patient. So this is a kind of a large diagram. I'm not elaborating this. So you also have to know when to do encirclage. So to begin with beginners, I think they should do encirclage in almost every case, because the thing is that you are not able to do a good base excision. Since you're a beginner, you're not able to go so close to the retina. So better to do a encirclage so that the base is supported and you can also see it for the rest of the surgery. Again, multiple break, pseudophakic RD with peripheral thick capsular rim, phakic RD where base excision is not so much possible. If it's a young patient, again PVR changes are, PVD cannot be induced till the periphery. Then peripheral PVR changes. So all this needs a support. One-eyed patient, even if you are very experienced, please put a buckle so that the base is supported and you have double chances of the retina surviving. Visualization. This is the first and foremost thing. A fresh fellow has a problem. He will, from the eye of the surgeon to the eye of the patient, there are so many interfaces. If there is any obstruction in any of these interfaces, any fogging anywhere, you're not able to see. So you have to address this. First thing, put a tape on your mask. If you're wearing spectacles, you will have fogging on your spectacles first. Again, there are these anti-fogging wipes that have come. So clean all the lens surfaces, whichever you can see, clean with that, so the mist will not fix on them. Again, there is this wrench. Some people have a wrench, some people have a side tray. You put a drape on that, so the air coming out from the nostrils of the patient does not fog any of your lenses. Again, a gauze piece at the lateral canthus will help drain any fluid which is put during the surgery. And a cotton pellet, wet cotton pellet at the nasal, medial canthus. It will help avoid fogging from the patient's nostril. Position of the head. It has to be parallel to the wide field lens. And slightly you can tilt the chin up by 10 degrees. Temperature and humidity has to be low, like 16 to 18 degrees Celsius temperature and humidity less than 40. Position of the ports. The position of the ports actually, SN, the you know that it is SNQ, STQ and INQ. But in case of a retinal detachment surgery, it is better to be more close to the horizontal, so there is more maneuverability while you're doing the surgery. Now again, before starting the surgery, check your IPD, check where the bed height foot switch is, check whether your microscope foot switch, where the magnification increase, decrease, depth increase or decrease. You have to check before that, and check the ergonomics. Your back should be straight, you should be comfortably seated before starting the surgery. First thing that I do is increase the magnification to the maximum. Then I focus at the limbus vessels. Then after that, I will bring it back to a level where all three sclerotomies are focused. After that, I will again take the light pipe inside, focus it to the maximum, bring the maximum magnification once more. Now I focus the disc. Then I decrease the magnification again so that the entire retina is focused in one image. So during the entire surgery, now I don't have to move. The whole retina is going to be focused in one. Okay. So I'll actually move to the video. 1 second. So you can see this. I am starting with the sclerotomies. Okay. First thing is when you put the infusion, you have to check whether it is in. The most common mistake that we do is we have put the infusion, we don't check, we switch it on, and it may be subretinal, it may be suprachoroidal, and we have ruined the surgery. Okay, this is the first thing. Next is now you see I'm checking with my light pipe. I've switched off the microscope. Okay, now I'm putting the other two sclerotomies, and we start the vitrectomy after this. Yeah, see I have, 1 second, I pause. 1 second, yeah, 1 second. Just see that I brought the magnification to the highest. I wanted to discuss this, is okay? I'll take some more time. Yes. Yeah, so, yeah, this portion is very important. Yeah, see magnification I've taken to the highest, then I brought it back after focusing at the limbus vessel. Now inside also I have taken the maximum magnification, then I focus the disc vessels, then I bring back the magnification to a position when I can focus the entire retina now in one go. Now throughout the surgery I don't have to move the focus or the magnification. Now I have done the core vitrectomy, I am trying to induce the PVD. See, from the disc, we start the PVD induction. PVD induction is a very important step during the surgery. So, you have to take your cutter as close as possible to the disc, don't touch the disc, and take it nasally. And take it nasally along the vessels. And the highest vacuum has to be kept, like 580 to 600 also. Whatever you have the highest, you keep that. Bring your cutter closest to the disc and then press the vacuum to the highest and then drag it along the vessels without touching. So you will get a plane and the vitreous will get separated. If you don't, then you use a pick. You use a retinal pick. After that you do a good base excision. In this one I see that there was some more vitreous, then I have stained. Again this is helping us to improve the intraop visualization. See? The intraoperative visualization I am improving with tricot, triamcinolone. Okay. Now after that, it's very important to do a good base excision after this. In base excision, what we do is that in the periphery, while we are going close to the retina, the vacuum has to be low, as low as possible. Sometimes even at 100, the retina keeps flapping in. So you have to keep it 50 or something. Okay. And after that, when you are inducing your PVD, when you go close to the primary break, as you've gone close to the primary break and you've removed the hyaloid on top of it, then the subretinal fluid automatically starts flowing. See, it has automatically started flowing, subretinal fluid. After this, you will do the FGE or fluid gas exchange. Okay. One more thing, while you're going around, you have to mark the break. This is diathermy. I have marked the break. So in this surgery, I didn't get any iatrogenic breaks. But as soon as you get the breaks, keep marking them with your diathermy. Otherwise, you might forget. And after FG, you can't visualize. So now FG is being done. You see that my flute needle is at the primary break. And this bubble is slowly filling up the entire retina. As you go to the peripheral break first, okay, then the nearer ones, like from periphery to center you have to move. The furthermost break you have to go first. As the fluid keeps coming to the center, you move on to the central break. And last of all, you have to move to the disc. So disc, keep alternating with the peripheral break. After this, you have to do the laser. Laser the brakes first and then the periphery 360 degrees. So before this, our speaker did say that he doesn't prefer to do 360-degree laser. But for beginners, please go ahead and do 360-degree laser because you don't know what you missed. If you have done a iatrogenic break somewhere in the periphery, you didn't see, it's better to laser it off. Last of all, this silicone oil injection. You see that I am injecting till my globe is 3/4 full. I'll keep visualizing. Once 3/4 filling is over, I will put a vent. Till it comes out of this vent, I will wait. Now it has come out and surgery is over. And you have to remove the last bubble with your flute. Sorry I took time because nobody is there,
No,
so I took chance.
it's okay.
Yeah, thank you so much.
Thank you. Very nice tips for the beginner. Only 1-2 point I want to add to her talk. One is whenever you are inserting irrigation probe, that is very important. You check the tip, ensure that it is inside your vitreous cavity. So either you depress and see the shining tip, that is very important, because if you suspect in some cases your 4 mm cannula may not be sufficient, then 6 mm cannula
6
use.
mm cannula.
Or if it is too bullous, not necessarily the same, you can choose other area also. And if it is very huge bullous, then obviously you have to drain fluid first. Otherwise 6 mm cannula is sufficient, or you may choose some other location. That is one tip. Second, rightly madam told at the end of surgery, always check the peripheral part and especially the insertion site of the probe. Check that, and if you suspect some anything, try to do his laser. So it is a very good tip. Thank you, Dr. Vandana.
Last of all, we should pack everything like this in the end because you will need them again. If you are a beginner, you will be in a setup where nobody is helping you. You have to pack and keep so that you can ETO it or plasma sterilize.
Thank you, Dr. Vandana, for a very nice talk.